So this is perfect right after everything that Dr. Duty said. I think there are many children that don't do as well as pediatric surgeons think they should do. So the question is why? And I wanted to just review what are the common problems that happen after a pull-through, what might cause them, and only by knowing what causes them can we figure out how to solve them. And then what is, as he touched on, what's the long-term outlook, not just as little children, but as adolescents and then adults. And just very briefly to remind everybody here probably already knows, but Hirschsprung disease happens in 1 in 5,000 and is more common in boys, and most of them now present as newborns because NICUs and pediatricians, neonatologists are better at recognizing the early signs. 100% of babies who are full term will pass stool within 48 hours, and if they don't, that's really a red flag that something's wrong with the colon, and usually leads to a rectal biopsy, where we find that there are no nerve cells in the rectum, and that absence of nerve cells, the aganglionosis, can extend in 80% of children just to the lower part of the colon, the rectosigmoid, and that's what's depicted in a similar picture as Dr. Duty showed. If you imagine the dots are nerve cells, they just stop, and this contracted part is the aganglionic part. In about 10% of kids, the whole colon can be involved, and in no more than 1%, the entire intestine will be involved. Probably everybody here who has had a kid or treated a kid with Hirschsprung's has started with a contrast enema, and the contrast goes up the rectum, and you can see how spastic and narrow it is until you get to the normally innervated colon up here. This is a biopsy which will show features of Hirschsprung's disease to the pathologist, and then the operation is done. You can see it's the same picture. This is an operation we did together that was great. So we're surgeons and we think, oh, we did the operation, they're going to do great. It's a simple disease, right? There's no nerve cells. Just remove that part of the colon. Everything will be fine. If it were that simple, then we can't really understand why at least 50% of them have ongoing problems. And the main problems are constipation. And these are rates that vary widely. They vary widely because the operations were done over variable periods of time, and they changed, as you learned, over decades. They also vary because how do you define constipation? How do you define fecal incontinence? Is it just by parent report, or is it by actual objective measures? So we'll talk about constipation, incontinence. You can see this rate as high as 75%, enterocolitis, and then all of these things, having an operation as a baby, having rectal dilations and irrigations and all typical things in newborns who face operations, the psychological consequences of that, and the challenges not just for the child but the family as well. The most dreaded complication of Hirschsprung's is enterocolitis. The enterocolitis is very interesting because the diseases of the nerves. So how do we explain enterocolitis, which is an inflammation of the intestine? It's the inner lining of the colon gets very inflamed. It causes diarrhea. The belly gets bloated. They can have foul-smelling stool, very explosive, and sometimes they can be quite sick with fever and sepsis and end up in the ICU. This is an x-ray. You can see on this x-ray how the belly just looks bloated. They're bulging here on the sides, a lot of gas in the intestine, no air in the rectum, and this contrast enema, which will show similar features in Hirschsprung's, shows this sawtooth pattern. This is contrast in the intestine, and on the outside you can see these spiculations. That sawtooth appearance suggesting a very strong spasticity of the wall. So enterocolitis is this inflammation. Now, it can happen before or after the pull-through. It can happen in the part that has no nerve cells. It can also affect the part that has nerve cells. And so we really don't understand the cause of it. We have some ideas. It may be related to abnormal immune function in the intestine, abnormal types of bacteria present in the intestine, but we don't know what the reason is yet. It used to be that 33% of children who got enterocolitis would die from it. That's from a paper in the 1960s. Fortunately, things got much better. Everything got better. Antibiotics, critical care, our awareness of the problem. And now, at least no more than 1% probably who develop enterocolitis will die from it. But once you have enterocolitis, you're at risk for more episodes of enterocolitis. You're at more risk for having long-term problems with bowel function. That can be constipation, soiling, and unfortunately kids that develop enterocolitis are then in a group of kids who are more likely to end up with a colostomy. It's the most common cause for hospitalization, and it significantly increases the costs associated with caring for the disease. So it's really important that we understand what the causes are, but also to address it early if it happens. So who's at risk? Well, everybody who has Hirschsprungs. Before and after the pull-through, it has about the same incidence, in the range of 10 to 40%. It's important that families first be aware of the signs. So nobody should leave the hospital after their pull-through or after the diagnosis of Hirschsprung's without knowing that if your child develops distension and diarrhea, you can't just assume it's a viral illness. You have to think Hirschsprung's enterocolitis first. Unfortunately, even today, if you end up in the ER at another hospital, a smaller hospital, they often have never heard of Hirschsprung's enterocolitis. So the parent really holds some of the responsibility to, the surgeon and the gastroenterologist first to teach the parent, and then the parent to be aware that this can happen. We have to also remember that of all kids with Hirschsprung's disease, which presents with constipation, of all of those, 10% present with diarrhea. So 10% of diagnoses of Hirschsprung's are made in children who present with enterocolitis first. So when a kid comes to the ER, maybe a 2-week-old, with bloating and diarrhea, somewhere in the back of our mind we should first ask, well, when did he first pass stool as a baby? Was it delayed? And we should remember that Hirschsprung's can, oddly enough, present with diarrhea. If you've had prior enterocolitis, you're at higher risk. If you have total colonic Hirschsprung's, Down syndrome, these are all things that increase the risk for for enterocolitis. So since we don't know the cause, we don't really know the treatment, but we know Flagyl works as an antibiotic. So why that works, maybe it's changing the bacterial flora, we don't know. Dilations, irrigations, people who've had enterocolitis with their children know that that helps a lot. It flushes out the stool and is very useful. And if they get really sick, a lot more antibiotics, admission to the hospital, and in a very small number, they may need an ileostomy. Now, constipation is an interesting problem. The kid has their pull-through for Hirschsprung's, they're doing great, and a year later, in this case, massively distended, and in this child, a rectal irrigation let out a liter of stool. So why did that happen? And we have to go through, whenever we see a kid who has obstructive type symptoms or constipation, we think of the different causes. The simplest, the one the surgeon likes, is a mechanical problem, because that we can actually fix. Maybe the pull-through colon, you can see here, was twisted as it was brought through, whether it was a Swenson or a Suave operation. Dr. Duty explained to you the muscular cuff in a Suave operation. You leave the muscular wall of the rectum and pull through the bowel, right through it. That can be too tight, the muscular cuff, or you can get a stricture where the colon is sewn to the anus. So for these things, typically an operation needs to be done. It's a mechanical problem and has a mechanical solution. Then we get a little more confusing. What if there's no mechanical problem? Well, as he mentioned, that would be found with a physical exam often, or a barium enema. But if those things are normal, then a biopsy is very valuable. Sometimes we pull through the transition zone. Here you can see a nice density of nerve cells. Here there's none, but in the middle there's that transition. We don't know what's wrong in the transition. Not enough nerve cells, wrong type of nerve cells. And so the thought is that about a third of people, of children who have need a reoperation for constipation, have an abnormal biopsy. So the transition zone was pulled through. All of these cause the bowel to function poorly, and they need a redo operation as well. Well, unfortunately now, if you have a normal rectal exam and a normal barium enema and a normal biopsy, the question is what do we do? So we come up with possibility number 3. You have to remember that Hirschsprung's disease isn't just the absence of nerve cells in the colon. The anal sphincter is normal. It doesn't work. It doesn't relax. Normally, when stool reaches the rectum, the sphincter relaxes, and then that would allow you to stool. Normally, you control the stool till you get to the bathroom because the external sphincter tightens. You have control over that one. But the internal sphincter is involuntary. It relaxes normally. In Hirschsprung's disease, it doesn't relax. So you can imagine the rectum fills with stool and the sphincter doesn't relax. Now that can cause an obstruction and lead to constipation. It's important to do anorectal manometry, where a balloon is blown up in the rectum and we check the pressures, the relaxation of the sphincter. And we find that test to be very helpful. Ultra-short segment Hirschsprung's disease is a term that people use. We think it's the same as this non-relaxation of the sphincter, internal anal sphincter achalasia. So in those conditions, they can be diagnosed with manometry. If you have too tight a sphincter, it doesn't relax and it's too tight. That's a situation we see in Hirschsprung's. All of these things cause obstruction. Nowadays, and this was started in Toronto, was one of the first centers to show that Botox injection into the sphincter will relax it. Botox relaxes muscle. That's why some women like Botox, because it relaxes the face, the muscles in the face, and it eliminates wrinkles. It does the same thing to the muscle in the anus. It relaxes it, and therefore it allows easier defecation. It's temporary, and therefore needs to be repeated in many people, but often after a couple of injections, we find that the sphincter then has improved function over time. So Botox has been a real benefit in children with abnormal sphincter function after Hirschsprung's pull-through. Now you get to a really complicated group. If everything so far has been normal, so there's no mechanical problem, the biopsy's normal, the sphincter works well, now you're left with, why are they constipated? Unfortunately, Hirschsprung's disease must be more than just the absence of nerve cells, because the colon that's left behind, even though it has nerves, sometimes just doesn't work, and we don't know why that is at all. We can show it doesn't work if you eat sitz markers, the little rings we give some children. We'll give them 50 rings to eat, do some x-rays, and in normal people, by 7 days, all the rings are out of the body, but in Hirschsprung's, with colon dysmotility from any cause really, the rings are just sitting there. There's no motility. There's a lot to learn still about Hirschsprung's. It must be, I think, that the nerves are probably just not developed appropriately. The nerves in the intestine are incredibly complicated. There's as many nerves as in the intestine as in the central nervous system, the brain and spinal cord. There's the same types of nerves, maybe 20, 30 different subtypes of nerves. Each nerve has to make the right type of neurotransmitter to send signals to the muscle, to the lining of the intestine. And if any one of those is missing, that would be sufficient to explain a problem with colon function. We aren't good enough yet to know what's normal, and therefore we certainly don't know when it's abnormal. This is what a child might look like, a barium enema with a massively distended colon. This colon will never work. In these kids, bowel management is the first step. Bowel management just refers to an aggressive laxative management, sometimes with or without enemas. Enemas are very difficult at this age, so we often move on to antegrade enemas, which I'll mention in a little bit. But antegrade enemas are where you can give the enema not from below, but from the top, from the beginning of the colon. They're referred to as ACE procedures, which I'll get to. And in somebody like this, whose colon is this stretched out and will never work, an ileostomy turns out to be probably the best option. And then you have this category where, unfortunately, a child who's been through a lot with his rectum, bowel movements, starts to associate defecating as a painful event, and therefore will start to withhold stool. It leads to what we call functional constipation. They avoid stooling, and it's very difficult to treat this. If the child is older, cognitive behavioral therapy can be helpful. There is some benefit to amitriptyline, actually, in these kids to stop that transmission of the sensation of stooling, to stop it being sent to the brain as a painful stimulus. And so there's ways to intervene, but this is really a challenge. I'm not going to go through this. It's similar to what Dr. Duty showed, but obviously we have to, when we see a kid constipated, a physical exam, mostly a rectal exam, a barium enema, and a rectal biopsy are very important, and the anorectal manometry is also very important. And based on all those, and thinking about the 5 causes of constipation after a pull-through, we can come up with what we think is the best treatment plan. Now, this is an interesting problem, fecal incontinence, because it's very underreported in the literature, at least in pediatric surgery. These are 4 different studies, and you can see the age of these kids. You know, this one had 84 kids, 12 years of age average, 16 or 10 years of age. So these are now getting older, pre and into adolescence. 39% in this study had frequent soiling. 32%, another 32% here, and in some cases, this is significant. We have patients who the school won't allow them to go to school because they have soiling, and it's really difficult for them to make friends. And so incontinence is something we need to be aware of and really address when it occurs. Not a big deal well, we don't count it in babies. We don't count it as fecal incontinence until they're at least 4 years of age. And this study, 72 patients with 76% incidence of fecal soiling. And remember the criteria here, some people are including just a little bit of staining on the diaper, and some are counting frank fecal accidents. How do you control continence is very complicated, and there are many reasons that people have fecal incontinence. You just have to imagine the interplay between the colon, the rectum, and the sphincters. All of those have a part to play in maintaining continence. And each of those has motor function, sensation. There's anatomic factors. There's a certain angle that the rectum takes as it enters the pelvis, and that anorectal angle is very important in maintaining continence. Your colon isn't just a straight tube. It actually has muscles that make it take an acute angle. So there's compliance. Compliance means you have a nice narrow caliber stool, and when stretches with stool, it causes a sensation, and that sensation can be sensed and interpreted, and a response is to squeeze. If the colon is very stretched out, compliance decreases. The body doesn't even sense that the rectum is stretched, so nothing happens, so it gets more stretched. Then there's also the stool consistency makes a big difference, which is why some laxatives work. And then we talked about the anorectal reflex, that the rectum tells the anus to relax. Actually, the anus also sends signals back to the rectum. So continence is very complicated. When we see a kid with fecal incontinence after a pull-through, the first thing to know is he incontinent or is he actually constipated? If you're very constipated, stool will leak around, the liquid stool will leak around the constipated stool, and then it looks like the kid's incontinent, when in fact his problem is constipation. So that's pseudo-incontinence and needs to be distinguished from this. Kids who are truly incontinent, you have to think first about the sphincter. Was it damaged during the operation, or does he just have abnormal sensation? You just heard about the importance of sensation in the rectum. Remember, the nerves are missing down in that part of the body. So not only does the colon doesn't squeeze, it doesn't sense. It can't tell that there's stool there. And he mentioned also if you sew the colon too close to the bottom of the anus and you miss that, you don't leave behind that last bit of the anal lining, that may also, we don't know. It's possible that that's not as important as we used to think, but the physical exam will tell us whether or not the operation was done at the right level. For these kids, they need a good physical exam, and again, the anorectal manometry to see how the sphincters are working. And based on those results, you can keep many of these kids clean with an aggressive bowel management program. Now, another interesting problem is hyperperistalsis. The colon normally squeezes stool, and then it stops at the rectum. The rectum serves as a brake, because the job of the rectum is to hold a reservoir of stool, so you can hold stool until you want to evacuate it. But if you remove the rectum, like everybody who has Hirschsprung's disease, now there's no brake. And the peristaltic waves can go all the way down to the anus. So now you have squeezing all the way until the stool comes out. That's a challenge in anybody who's had that portion of the colon removed, kids with imperfect anus or Hirschsprung's disease. It's also interesting, whenever you operate on the colon, you increase the frequency of colonic contractions. You increase the number of them, their frequency, and they even occur at night when normally they do not occur. So for some reason, removing parts of the colon or operating on it has that effect. In these kids who have this hyperperistalsis, a high-fiber diet can be helpful, and also maybe even Imodium to slow motility. Many of us are afraid of using Imodium in Hirschsprung's because we don't want to make constipation worse, but if this is the cause, then slowing the colon may actually be beneficial. And interestingly, amitriptyline, which we talked about earlier to avoid the painful sensation of stooling, also slows colonic motility and can be a useful treatment. And then there's other reasons. Some kids have diarrhea or fecal incontinence because they have a little bit of enterocolitis. They're not distended and having massive diarrhea, but they have a low-grade inflammation, and we have to think of that as a possible cause. Food allergy or intolerance we'll hear a little bit more about later in the panel session. Very underreported, but it's thought that up to 2/3 of kids with Hirschsprung's have some food allergy or sensitivity, which can lead to bloody stools or frequent stooling and diarrhea. And then the bacteria, the microbiota is the bacteria that lives in the colon. We live in this beautiful relationship with our bacteria. There are a lot of them. And if the bacteria are abnormal, it wreaks havoc on the colon, which is why the probiotic industry is doing very well right now, and with good reason. And then finally, we mentioned the behavioral component. If kids start to avoid stooling and the rectum becomes very distended, they just completely lose the sense of knowing when they need to go and when they don't. Again, in these kids, if they're old enough, behavioral therapy is helpful. We do have good luck with pelvic biofeedback or pelvic physical therapy, but they have to be older. And again, amitriptyline or gabapentin, which both address the painful stimulus of stooling and get them back to a more normal stooling behavior. I'll just briefly mention the antegrade colonic enemas. When you need to aggressively manage bowel management, which is laxatives, it can be done either for constipation or for incontinence. If a child is incontinent of stool, if we clean out the colon daily, then it's empty, and there'll be nothing to leak until the next day when they get the next clean out. So if we can get the colon clean, it'll stay clean. And retrograde enemas are traumatic for children, particularly toddlers and young school-age children. So antegrade enemas are very effective. They really improve quality of life. The retrograde ones are hard on everybody. The antegrade ones are better tolerated. Appendicostomy and cecostomy are the two most common, and that's a whole other topic of discussion. So fortunately, long-term outcomes improve as the child gets older. So it really is the first few years after the pull-through tend out to be the hardest. Enterocolitis, in fact, rarely happens after school age. After age 5 or so, we don't see that much of it at all. And when we talk about incontinence, adolescents, and this is a big study, a meta-analysis of 2 published studies, adolescents had many fewer fecal problems than children. And the quality of life and the disease-specific functions, so how they did with bowel movements, soiling, all that, improved significantly with age. In one study of 72 kids, those under 12 years of age, 74% had some degree of soiling. Once they were over 12 years of age, only 26% had soiling. And even of those, they used 12 years as a cutoff. But in other studies, once the child reaches puberty or 15, the problem almost goes away entirely. So quality of life is a big thing to think about with Hirschsprung's disease. This part of the body, when it has surgery and when it doesn't work right, results in body image issues, emotional issues, social issues, but it doesn't need to have those consequences. If the child has the proper supports and the proper physicians and issues are addressed as they arise, all of this can be mitigated. But in some kids, those difficulties can continue into adolescence and adulthood if they don't get the proper support along the way. I think the take-home message is that as surgeons, we think of Hirschsprung's disease as a problem of a newborn. It's a lifelong problem. It has chronic consequences if those problems are not addressed as they arise. If they're addressed aggressively early, not just the medical and surgical part, but the psychosocial challenge as well, then the quality of life will be excellent. So I think we need to be aware of those challenges. Long-term follow-up is important, and it should be by people who are familiar taking care of kids with Hirschsprung's. Parental support is critical. I mean, the fact that parents are here already tells you what kind of parents are taking care of these children. And medical support is critical, obviously. We need now the kids, thank God, are living full, normal life expectancy, obviously, now with Hirschsprung's. It wasn't like that decades ago. So now we need adult physicians to work with the pediatric physicians who understand Hirschsprung's disease so that we can transition these kids into adulthood seamlessly. And obviously research is a key component to getting much better at understanding the problem